So again, good morning, good afternoon, and good evening. Thank you for joining us today. We encourage you to use the chat to ask questions in English or French at any time to the group or directly to any of the moderators if you need technical assistance. We'll be using Mentimeter today. You can use this on your phone, tablet, or laptop, and we'll provide instructions on how to access and use Mentimeter in a few minutes. QR codes and links via the chat will be provided throughout the webinar for you to access resources and tools. And the webinar recording, presentation, and links to resources will also be shared by email. So thanks again for joining, and we'll go ahead and get started.
Hello, everyone. Good morning and good afternoon. Thank you so much for joining us, and welcome to this first webinar in the Breakthrough Research Legacy and Learning series. My name is Lindsay Swisher, and I am the Agreement Officer Representative at USAID who oversees the Breakthrough Research Project. Breakthrough Research is USAID's flagship social and behavior change research and evaluation project to drive the generation, packaging, and use of innovative SBC research to inform programming. Implemented from August 2017 until this forthcoming July 2023, Breakthrough Research is led by the Population Council in collaboration with the consortium partners Tulane University, Avenir Health, Population Reference Bureau, Institute for Reproductive Health at Georgetown University, and Ideas 42. Breakthrough Research also works closely with its sister project, Breakthrough Action, as well as other implementing partners working on social and behavior change and service delivery. Breakthrough Research's approach is to foster collaboration and shared learning, promote evidence-based solutions to improve health and development programs, generate evidence in the field of SBC, and put evidence into practice by elevating the impact of evidence-based SBC programs. Evidence generation continues to be critical in the field of social and behavior change as we build out our knowledge base around what works, synthesize and package that evidence into shareable formats, and get it into the hands of implementing partners, donors, governments, and key stakeholders. Breakthrough Research has done a lot of critical work over the last 6 years, spanning a variety of health topics. So today you'll hear about their work on provider behavior change, an important topic for the Office of Population and Reproductive Health. While PBC, or provider behavior change, is an area of interest and priority across all global health areas within the family planning and reproductive health space, PBC has a critical role to play in the way that, say, contraceptive users ask questions of and interact with providers, the way that youth seeking reproductive health services feel when they enter a clinic, the way that men may engage in supporting family planning and reproductive decision-making, and so much more. So we look forward to sharing the work that Breakthrough Research has done in this space. And with that, I'd like to hand things over to Laura Reichenbach, the Project Director for Breakthrough Research, to kick off the rest of the webinar. So Laura, over to you.
Thank you, Lindsay. I want to welcome everyone to today's webinar. My name is Laura Reichenbach, and I am the Project Director for Breakthrough Research. Breakthrough Research has had a productive 6 years, and I want to share a quick snapshot of a few of our metrics. The project has worked in 19 countries and engaged with 21 global and country partners on 53 research studies. This has resulted in 27 peer-reviewed publications and 94 citations to date across the 4 priority technical areas of the project: provider behavior change, SBC and the enabling environment, advancing SBC measurement, and costing for SBC. Today's webinar is the first of 4 complementary legacy and learning webinars. These webinars are intended for programmers, researchers, development partners, and donors, and are designed to be an interactive learning opportunity. Please join us for the full complement of this legacy and learning series. More information will be shared at the end of today's session. For this webinar, we'll highlight evidence, insights, and learnings from the past 6 years from Breakthrough Research's work to advance provider behavior change, PBC programming, and fill critical PBC evidence gaps. We'll also share resources and evidence-based practical tools you can use to strengthen PBC programs, measurement, and research. First, We'll start by briefly setting the scene for provider behavior change in family planning. Next, we'll share some of Breakthrough Research's state-of-the-art evidence produced over the past 6 years of the project to advance PBC programming, followed by sharing a selection of Breakthrough Research's PBC tools you can use. We'll then share a call to action for programmers and implementers, researchers and donors. What can you, in your role, do next as we look to the future of PBC as an SBC approach to quality of care and family planning? I'll now turn it over to Amanda Calamar, the Technical Director for Breakthrough Research.
Thanks, Laura. As mentioned at the start, we'll use Mentimeter throughout today as a way to hear from you all throughout the webinar. You can access Mentimeter through your phone or your laptop. If you're using your phone, you can use the QR code on the screen. Scanning it will take you directly to our page on Mentimeter. On your phone or laptop, you can also go to www.menti.com and enter the code 58657498, the code on your screen, and this will take you to our page on Mentimeter. We'll give everyone a minute to get there, and once you're there, if you can click the thumbs up on the page it brings you to, that will let us know how many people have successfully connected to Mentimeter. Great, I see lots of thumbs up and so people connecting to Mentimeter, so we'll go ahead and get started. So, whoops, sorry about that. Oh boy. So first, where are you joining this webinar from today? Please let us know by placing the blue dot near your geographic location and pressing submit. You'll see the results live on the screen here. Wonderful. It's great to see so many colleagues from so many different geographic locations joining today. So next, have you ever used provider behavior change approaches as part of your work? Please let us know yes, no, or if you don't know or unsure, and you'll see the results live here today. Great, lots of people have used provider behavior change approaches in their work. Great to see. So next, how would you rate your level of knowledge of PBC evidence and approaches? You can drag the blue dot on the scale to select your rating from not knowledgeable to highly knowledgeable and press submit, and we'll see the results live on the screen. Great, so we're about halfway in between, and so hopefully by the end of this, we'll be towards the highly knowledgeable side of the scale. And finally, for right now, to get to know you all, do you consider yourself to be a program designer or implementer? Are you a researcher or M&E officer? Are you a donor or a stakeholder, official, or policymaker, or none of the above? Great. We have a great mix of people on the line, which is wonderful to see. So thank you all for your participation in this first Mentimeter exercise. It's great to hear from you, and we look forward to your participation via Mentimeter again in a few minutes, so don't have it go too far. So now let's set the scene for provider behavior change in family planning and dive into the evidence. Today, we'll be sharing just a selection of Breakthrough Research's work over the past 6 years, organized around key messages we'd like to leave you with. The links that we provide throughout the webinar can be used to go deeper into the evidence and the tools shared. We'll also share a link at the end of the webinar to a collection of a larger body of Breakthrough Research's work on provider behavior change. As a first key message for today, an SBC approach within provider behavior change to improving quality of care in family planning addresses behavioral antecedents of provider behavior and has the potential to result in multiple impacts at individual, community, and system levels. Provider behavior defines a range of actions that include, but are not limited to, facility management, adherence to clinical protocols, supervision, and client-provider interaction that is the outcome of a complex set of factors that are both internal to a provider, for example, attitudes, values, and beliefs, and external to a provider, for example, supervisor support, access to professional development, and a supportive workplace environment. Understanding what drives providers' behaviors and how they impact client-level outcomes is key to improving health services. Providers' behaviors can significantly influence patients' experience of the service and their likelihood to adhere to treatment and recommendations, and potentially alter patients' likelihood to re-engage with health services to improve health outcomes. And yet, provider behavior change is complex. There has been limited evidence on approaches to measure and address provider attitudes and provider bias, while at the same time, there's also been a need to better understand the pathways from intervention to outcome. Along this pathway, it can be difficult to determine how the PBC intervention influenced the intended outcomes, particularly for more distal outcomes, including client outcomes such as informed and voluntary method choice and uptake, method continuation, and experiences of care. Provider behavior has traditionally been viewed through the lens of health system strengthening and through quality of care frameworks that take the sole perspective of the client. These frameworks often do not reflect behavioral determinants of the provider, such as attitudes, self-efficacy, and perceived norms. Breakthrough Research's provider behavior change work has focused on PBC approaches that seek to affect provider outcomes to improve quality of care, including for family planning. This includes improvements in the quality of care itself, as well as in client-level outcomes. To do this, understanding both the system-level determinants and the individual determinants is needed to achieve a comprehensive understanding of provider behavior. We know that effective client-provider interactions that are influenced by provider behavior, are essential to consistent demand and uptake of family planning services. The quality of this interaction, as mentioned, can be influenced by a provider's knowledge, attitudes, biases, and expectations, as well as structural factors such as method availability or privacy of counseling space. We also know that interventions informed by behavioral economics as a PBC approach hold promise to improve family planning outcomes through provider-facing interventions. These interventions are grounded in the behavioral economics principles that first, human behavior is extremely complex, but often predictable, and second, the context in which decisions and actions are made and taken greatly influences behavior. Given all of this, it's important to understand that health systems are comprised of interconnected stakeholders whose effectiveness is influenced by power dynamics and by a range of drivers of provider behavior. To better understand this, we'll highlight some of the key evidence for PBC for family planning that Breakthrough Research has generated over the past 6 years, including the Research and Learning Agenda for Advancing PBC Programming, an evidence review and analysis of PBC opportunities, and an analysis of expressions of power in providers' experiences and behavior. You'll now hear from those on the breakthrough research team involved in developing these resources, and they will be available at the end of the webinar to answer questions.
Hello, everyone. My name is Sanyukta Mathur, and I'm going to be talking about the research and learning agenda for advancing PBC programming, provider behavior change programming. Early in the project, we realized that although there were examples of innovative and effective ways to influence provider behavior, opportunities existed within the SBC space to explore and expand that knowledge base. Breakthrough research with input from USAID and implementing partners developed a way forward for improving the knowledge, attitudes, and behaviors of healthcare providers toward their clients. Through a collaborative and consensus-driven process, we developed 2 research and learning agendas, or RLAs, including one focused on provider behavior change programming. The PBC RLA that lays out a set of questions designed to help discover what we need to understand better about providers' behaviors and improve provider behavior change programming. The identified research questions were grouped into 4 areas. First was a set of questions around organizational characteristics and values. These questions ask us to consider which norms beyond individual provider level norms and attitudes, looking at what facility or community level norms shape provider behavior and how that impacts client-provider interactions. The second set of questions focuses on intervention strategies that create an enabling environment for positive behaviors and which strategies improve the quality of provider counseling. The third area includes a set of questions around effectiveness, specifically asking if and how addressing provider behavior leads to improved quality of care and health outcomes. Finally, under measurement, questions touch on best ways to consistently assess quality of client-provider interactions from client and provider perspectives, and how to measure provider attitudes and norms and biases more consistently. Together, these RLAs identify cross-cutting SBC knowledge gaps and key research questions with broad applicability at global, regional, and local levels across health sectors. The goal in developing these RLAs was to help guide decision-making across sectors, foster collective learning, reduce duplication of efforts, and maximize the impact of research and programmatic investments. There was a clear recognition among stakeholders engaged in this process that in order to advance this research and learning agenda, concerted and coordinated action will be needed from a range of stakeholders, including donors, SBC and service delivery organizations, health system actors, governments and policymakers, as well as research institutions and universities. By promoting and adopting this agenda, current and future investments can be maximized to achieve the best possible health and development outcomes. What you will hear today at this webinar is a snapshot of the collaborative work to date that has tried to chip away at some of these persistent barriers to advancing provider behavior change programming. Thank you.
Thank you so much to Sanyukta for that. You can access the research and learning agenda for advancing provider behavior change programming using a QR code on the screen or using the link shared in the chat. Now we'd like to share some key PBC insights about interventions with the promise to be informed by behavioral economics from an evidence review and analysis of provider behavior change opportunities.
Hi, my name is Janice Smith, and I'm a managing director at Ideas 42. One of the early pieces of work that we did around provider behavior change was an evidence review and analysis to identify particularly promising opportunities to apply behavioral economics to improve provider behavior. In this review, we looked at 27 different provider behaviors from a range of different health areas. And in order to identify those particularly promising opportunities for research and innovation, we sought to answer the following questions for each one of these behaviors. First, what was the strength of the link between the provider behavior we were looking at and health outcomes? Or in other words, what was the potential for impact by focusing on this provider behavior? Second, we sought to understand what interventions had been tried in the past to shift this provider behavior, and what was the strength of the evidence as a means to identify opportunities where there may have been a particularly promising behavior from the perspective of impact, but scant evidence around effective interventions. Finally, for each one of these challenges, we also sought to understand the degree to which the underlying challenges related to this behavior could be addressed with a behavioral approach, rather than perhaps an investment in infrastructure or building clinical skills that might be better addressed through other approaches other than one of behavioral economics. Now, specific to family planning, this review and this assessment of the analysis resulted in identifying two particularly promising provider behaviors that could be addressed using behavioral economics. These were that providers counseled women on a full suite of methods, and that providers counsel women in union on spacing. Now, in this review, you'll see the depth of the analysis. You'll see very concise synthesis of the intervention approaches that have been tried, as well as, again, other opportunities outside of these two behaviors where we believe that behavioral economics could best be applied. A companion piece to this original evidence review was a piece that we completed recently, which really draws from years of doing research from the lens of behavioral science, as well as program design around provider behavior. What we sought to do was synthesize this broader body of work into a series of insights that we believe are cross-cutting across many health challenges, as well as the actual programming approaches that we tried that match each one of those insights. So as you can see on this screen, clinical cues, feedback loops, practical mismatches, multifaceted identities, and scarcity are 5 of the insights that we found cross-cut many of the challenges. And in this piece, you'll see details in terms of how this plays out for distinct health challenges, as well as what practitioners can do in terms of approaches to programming, which are evidence-informed. And both of these pieces can be found by clicking on the QR code. So we hope that you find them enjoyable, and we look forward to your feedback.
So thank you so much to Jana for that. As she said, you can find these pieces using the QR code on your screen or using the links that have been shared in the chat. We'll now go back over to Sanyukta so that she can share with us some findings from an analysis of data from providers in 4 countries.
Hello, I'm going to talk to you about expressions of power in providers' experiences and behavior. A growing body of literature shows that healthcare providers face a range of challenges in their work that are often internalized and affect how they provide services to clients. However, few empirical studies to date have focused on exploring power through provider perspectives in relation to their performance and behavior. The Breakthrough Research team led a multi-country secondary qualitative analysis that investigated how power manifests and can be shifted to optimize provider behavior change approaches across health areas and geographic contexts. Using qualitative data gathered from different cadre of healthcare workers from Kenya, Malawi, Madagascar, and Togo, the results are intended to help promote quality reproductive, maternal, and newborn care by offering insights for PBC programming. For healthcare workers, several types of power may be at play, and in our study, we drew on an existing power framework and explored 4 domains. First, the beliefs and perceptions related to the sociocultural contexts that affect providers' power to engage in their therapeutic counseling relationships. 2, how practices and participation reflect norms that influence behaviors and engagement within the purview of one's roles. 3, the extent to which access to assets, including physical, financial, and human resources, influence provider behavior. And 4, how norms are affected by health systems, the structures, policy, and their governance. Let me give you just two examples from our analysis and data. Looking at the beliefs and perceptions of providers by communities and vice versa gave rise to power dynamics between healthcare providers and clients' communities. These are underpinned by local assumptions about what it means to be a healthcare provider. For example, provider reputation could be built when positive HCP client interactions were shared within a community, or the opposite, as shown by this quote on the left. Access to assets includes access to material, spatial resources, opportunities for advancement and supervision, quality, and emotional support. We found, unfortunately, limited access to assets across healthcare provider cadres and gender in all 4 countries, though non-senior facility-based providers at health centers describe it most acutely. Beyond adequate remuneration, community-based healthcare providers in Togo express a feeling of underappreciation by the health systems in which they work. This leads to a perceived unfair treatment with respect to CHW's work compared to that of facility-based providers, placing higher value on the latter, as one community-based healthcare provider describes in the quote presented here. Integrating power-enhancing, equity-promoting approaches in PBC programming, including for family planning, quality of care, can improve collaboration and feedback among healthcare providers and offer structural changes for quality. These could include participatory mechanisms for routine community feedback about the experience of client-provider interactions, policy changes that ensure adequate supervision, equitable access to resources, opportunities for advancement, and improved task sharing that can facilitate provider performance, team building strategies that could help address the current process of collaboration to address relations across cadres of providers and build trust, to challenge authority when it's needed to improve care. Further incorporation and investigation of these types of expressions of power into implementation research design, intervention selection, and PBC outcomes, including shifting power dynamics among healthcare providers, is needed to strengthen PBC programming. Thank you.
So thank you so much to those presenters, and we look forward to hearing from you all today. With any questions you have, please do share them in the chat, and we'll try and get to as many as we can during the discussion at the end. We look forward to hearing from you in the future as you apply the evidence found in these resources to your own work. Right now, we'd like to hear from you again using Mentimeter. So please go back to where you left off on Mentimeter, or if you need to rejoin us, please go to menti.com and enter the code you see on the screen here, 58657498, or use the QR code to take you to Mentimeter. I'll give everyone a few seconds to rejoin us, and then we'll go over to Mentimeter and ask a few questions. Okay. Great, I see folks have rejoined us. Wonderful. So we just heard about the evidence gaps highlighted in the research and learning agenda for advancing PBC programming. We'd like to know what you're working on related to these evidence gaps. So please place the blue dot near or on the square of the evidence gap most related to your current work. Is your current work about the organizational characteristics and values that influence provider behavior? Is it about PBC intervention strategies, or about the effectiveness of PBC interventions? Or is your current work about measurement? Wonderful. It's great to see so many of you working on all of the evidence gaps identified in the research and learning agendas. We have people working on measurement, on effectiveness, on intervention strategies, and some fewer blue dots in the organizational characteristics and values, but great to see that there's work spread across these 4 evidence gaps. So thanks again for participating. Don't put Mentimeter too far away. We'll use it again in a few minutes. As we continue to delve into PBC and SBC approaches for quality of care and family planning, we know that defining and measuring provider behavior and its determinants is complex and dynamic. It requires continuous nurturing, and it is imperative to sustain change that contributes to improved family planning outcomes for clients. Over the past 6 years, breakthrough research has developed tools that can help us better understand and measure provider behavior and its determinants as a way to improve quality of care and family planning. Today, we'll highlight 3 of those tools that are available to you to learn from and to use in your own work. We'll now be taking you on a PBC Tools You Can Use tour, where we'll share a short presentation aimed at highlighting what the tool is, why it's needed, and how you can use it, followed by interactive feedback through Mentimeter and a short question and answer discussion. So members of the Breakthrough Research team will share 3 PBC tools you can use. First, Leanne Doherty of the Population Council will share the PBC Measurement Learning module. Following that, Martha Silva of Tulane University will share work that Breakthrough Research did to develop a provider attitude scale. And finally, Heidi Worley from the Population Reference Bureau will spotlight research that implementing partners have done to fill key evidence and learning agenda gaps. So over to Leanne for the PBC Measurement Learning module.
Welcome to the presentation on PBC measurement. Breakthrough Research is collaborating with Breakthrough Action to offer social and behavior change practitioners and researchers a suite of blended learning capacity strengthening e-courses and toolkits. The courses are self-guided and include a pre-post test, instructional video content, PowerPoints, knowledge check quizzes, and extra assignments and opportunities to further the discussion with other SBC professionals. The objective of these courses and toolkits is to improve the capacity among SBC practitioners and researchers to use SBC approaches to identify and apply solutions to challenges. The courses are available in English and French to reach a broad audience. During this presentation, I will provide you with a brief overview of one of the courses focused on provider behavior change measurement. The PBC measurement course includes 2 short instructional videos that last between 10 and 15 minutes and is accompanied by a how-to brief that participants can print for easy reference. In the first video, we define provider behavior and why we think it's important to focus on provider behavior change. In the second video, we delve into the topic of measuring different factors that are associated with provider behavior and how this can inform your work through examples from Breakthrough Research and other projects. In this presentation, we will highlight some content from the instructional videos to give you a sense of what is included. To begin, we put forth a definition of provider behavior from the Provider Behavior Change Implementation Kit. Provider behavior defines a range of actions that include but are not limited to facility management, adherence to clinical protocols, supervision, and client-provider interaction that is the outcome of a complex set of factors that are both internal, for example, attitudes, values, and beliefs, and external, such as supervisor support, access to professional development, and supportive workplace environment. These are to the provider. This definition establishes parameters of what we mean about provider behavior and how provider behavior change interventions can be used to influence provider behavior. As we begin to consider measurement of provider behavior change, we want to capture the range of actions a provider engages in, as well as the complex set of factors associated with these behaviors. To help us categorize these measures, we use select domains from the well-established behavior change model, Precede Proceed, as an organizing framework. We use this behavior change model as it considers individual level determinants and their interactions with system level determinants. These selected domains correspond to known factors influencing provider behavior and illustrate elements beyond health worker ability, such as competency and skills, that influence service provision, or specifically client-provider interactions. I will walk you through each of these 5 categories now and provide an example of a type of measure. More details are included in the course. Predisposing factors are an individual's attitudes, beliefs, and perceptions. For example, to measure a provider attitude towards unmarried individuals seeking contraception, you could ask the provider, would you offer this method to an unmarried person? Reinforcing factors are those that follow a behavior and determine, for example, whether a health worker receives positive or negative feedback by their supervisors. This could also include measuring job satisfaction, a construct that may include a range of questions to the provider about remuneration, workload, harmony in the workplace, on-the-job training, job stability, etc. Enabling factors are the resources and skills required to make desired behavioral and environmental changes. For example, the availability of medical supplies enables a health worker to offer health services which could be observed through a health facility assessment. Ability is the competency and skills of the provider, which can be measured by assessing counseling components. For example, did the provider provide information about different family planning methods? And finally, provider behavior, client-provider interactions, which addresses client reception, person-centered care, and client management, could be assessed by observed whether the provider welcomed a client, gave adequate answers to all questions, and explained what was going to be done to obtain client's consent. As you may have noted from the previous slide, the types of PBC measures require a range of data collection strategies. Mystery clients and client-provider observations enable us to capture provider behavior, but may require strict training of mystery clients or require a high volume of clients to be cost-effective. Client exit interviews enables us to better understand client outcomes, such as client satisfaction, but may be prone to social desirability bias. Provider interviews enable us to understand behavioral determinants, such as attitudes and biases, but can be disruptive to services to collect. Provider behavior change measurement is complex and encompasses both a range of behaviors to measure as well as complex environment of influencing factors. This course provides an introduction for how to approach PBC measurement and provides suggestions on types of measures and measurement approaches that can be used to further our knowledge about this important approach. To learn more about PBC measurement, you can use the QR code to access the learning course and related material, including the how-to brief.
Thank you, Leanne. And you all have the link to the how-to brief in the chat, and the link to the learning course will be shared in the follow-up email following this webinar. We'd like to hear from you again using Mentimeter. So please go back to where you left off on Mentimeter, or if you need to rejoin us, please go to menti.com and enter the code you see on your screen, or use the QR code to take you to Mentimeter. So for the PBC measurement learning course, first, a pulse check. Is the tool that Leanne just shared relevant to your work? Great, thank you for your feedback, and it's great to see that many of you see the relevance of this tool to your work, and we're excited for you to use it and hear how it went. So as a next question, in a short sentence, thinking about measurement of PBC approaches and interventions, tell us what you think the biggest PBC measurement challenge is. You can type in a short sentence into Mentimeter and hit submit, And we'll see the results live on the screen. And we'll use one of these to have a short discussion with Leanne. Wonderful. It's great to see, well, maybe not great, but it's great to hear your feedback on what's the biggest PBC measurement challenge. And so, Leanne, I wonder, I'm seeing two that I think relate to each other. I'm wondering if you can talk a little bit about the challenge that we see up top here around adequately assessing all aspects, and then also this challenge that we see in the bottom here around demonstrating impact. If you can just talk a little bit about how you think about this through the lens of PBC measurement.
Great, thank you, Amanda, and thank you everyone for this great feedback. I think, these, as I kind of watched these short sentences come through, I was just nodding in agreement that these are all definite challenges. And I think just broadly that PBC measurement is still quite nascent, and there's a lot of work to be done to continue to build this field. In terms of sort of thinking about measuring adequately all aspects and the impact, we have tried to do an evaluation of a PBC intervention. And one of the ways that we've kind of approached addressing these two aspects is to use different methods. So we've combined both qualitative and quantitative measures to take sort of a mixed methods approach to the evaluation. And to use existing tools as they're available. So for sort of the quantitative measures, we've leaned on sort of the SARA, the Serviceability Readiness Assessment tools, and the Service Provision Assessment from the DHS modules to get at some of the more health facility aspects, the structural aspects that might be contributing to provider behavior. And then as you'll see in the upcoming presentation, we've started to really think about what are some new measures that can be developed and tested that can get at the provider aspect, sort of the provider's individual attitudes and beliefs that might be influencing the behaviors.
Great, thanks, Leanne, and thanks everyone for sharing your feedback. This is really great to see, and hopefully this new learning course will help to address some of these measurement challenges. So now we'll go back over to our tools you can use to Martha with the provider attitude scale.
Welcome, and thank you for joining me. I'll spend the next few minutes describing the process we followed to develop a scale that measures provider attitudes that can be relevant across different health areas. The impetus for this work was the need for more robust measurement of the factors influencing whether and how providers provide high-quality care. As you have heard earlier in this presentation, or perhaps in a breakout room, another breakout room, the Breakthrough Research Project in its first year engaged in a multi-step collaborative process to define and prioritize research and learning agendas to advance social and behavior change evidence-based programming. The image that you see on the right corresponds to the research and learning agenda for provider behavior change, which was one of the identified priority areas. One of the key gaps identified was related to measures for provider attitudes. How can we best measure provider attitudes that influence their performance and adherence to timely and respectful client-centered care practices? We began this work by adapting Tavro's framework that explores how providers influence service use and the client's experiences with services. We are particularly interested in exploring provider attitudes that could apply to multiple health areas. And based on early literature reviews that Breakthrough Research conducted, we decided to focus on the conceptual provider attitude domains, which are perceptions of clients, attitudes towards their professional roles, and attitudes related to gender roles. We followed a multi-stage research process that included a literature review, development of initial survey items that were fielded as part of a large study in the Democratic Republic of Congo, and then further refinement of the survey items and response options through another study, a qualitative study using cognitive interviews, which was also conducted in the Democratic Republic of Congo. And then a third study where we retested the scale items through a provider survey was conducted in Togo. We found that the revisions that we conducted did help to develop a scale that worked well. We used a number of scale development criteria, including factor loading, to retain 14 of the original 23 items that we had originally tested. These 14 items loaded on a single factor, which indicates that our original conceptual domains of perceptions of clients, attitudes towards their professional roles, and attitudes related to gender roles were not themselves latent constructs underlying provider attitudes, but they were elements of each of these domains that were represented across the 14 items that we retained to form the scale. In examining what these 14 items did represent, and with the help of peer advice and a high-level review of the literature, the concept of authoritarian attitudes emerged. So now that we have a scale that measures authoritarian provider attitudes that fall within the three conceptual domains, we needed to explore whether these attitudes are important and what are they associated with. On this slide, we're showing you provider attitudes as measured by the 14-item authoritarian attitude scales, with beliefs about family planning services and perceptions of family planning service quality. The higher a provider scores in authoritarian attitudes, the lower they score on their beliefs that family planning services should be provided equitably to unmarried women and women without children. Similarly, the more authoritarian the provider's attitudes are, the lower the score on their perceptions of the quality of family planning services that the facility provides. To close, we started down this path of developing a validated measure of provider attitudes that had the potential to be applicable to multiple health areas. We wanted to better understand the attitudes that, among other things, influence provider behavior and can affect healthcare provision, and in turn affect clients' experiences with service uptake and continuation of care. We need to continue testing and validating these measures in other contexts, but so far we have identified reliable measures of authoritarian provider attitudes. These survey items measuring authoritarian provider attitudes are available for incorporation into future surveys with providers, and we have developed a short user guide and analysis guide to accompany them. I'd encourage you to think about this kind of measurement of providers that goes beyond training, skills, and competency. Thank you, and I'm happy to answer any questions you might have.
So thank you so much for that, Martha. Now we'll take a few minutes to hear from you all again using Mentimeter. So as always, please go back to where you left off on Mentimeter, or if you need to rejoin us, please go to menti.com and enter the code you see on your screen, or use the QR code to take you to Mentimeter. So for the provider authoritarian attitudes, again, first a pulse check. Do you see yourself using this scale in your work? Will you use it right away? Will you use it maybe in the future? Not at all, or are there still too many questions? Wonderful. It's great to see that more than a quarter of you are looking to use it right away. So that's great. Please access the resource via the chat to use it in your work as soon as you can. For those that say maybe in the future, please hang on to those resources when you're able to use it. And we look forward to hearing how you apply this scale in your work to measure provider attitudes. As a next question, do you routinely collect data from providers about themselves? Please let us know if yes, you do, no, because you don't need to, or no, but you do want to. Great. So just under a quarter of everyone does routinely collect data, and we see nearly half of you don't, but you want to, which brings us to our next question. So in a short sentence, tell us what you think the biggest barrier is to collecting data from providers, particularly nearly the half of you who want to, but aren't doing so. What's the biggest barrier to doing that? Great. Again, lots of barriers that we're seeing. And so, Martha, I know we have you on the line, and it seems that some of these barriers are coalescing around sort of two sort of categories. One I see is lack of time and resources, and a second is around lack of tools. I wonder if you can spend just a minute talking through a little bit about how you would think about these barriers to collecting data from providers so that we can measure things like provider attitudes.
Thank you, Amanda. Yes, I completely agree in terms of the logistics of trying to interview providers and getting them interested to buy into the research and also to see the utility of what of the data that we're trying to collect. That's always a challenge. And of course, the budgetary implications of that, of needing to go to facilities more than one time, and also needing to collect data from pretty much all of the providers in each facility, given that there's usually few providers if we're talking about primary care. So I think that I'm really interested personally in trying to see how useful this kind of tool can be incorporated into routine efforts, routine data collection efforts, which might also get to the issues of bias, of social desirability bias. What happens when you're collecting this kind of information with questions like the ones that we've developed over time? So
learning how to do that, and I'm really interested actually to hear from those of you who do collect data routinely. And maybe the next step would be exploring, is there even a shorter version of this scale that would work better for those routine systems? And so I think that's a direction that I would certainly be interested in taking this.
Great, thanks, Martha, and thanks to you all for sharing this feedback. And if you have any specific questions, again, please use the chat and we'll try to address as many questions as we can during the discussion at the end. So again, please don't have Mentimeter go too far. We'll use it again to hear from you all in a few minutes. But now we'll go over to Heidi, where she'll tell us a little bit about the research spotlights as a tool that you can use.
Hello, everyone. My name is Heidi Worley. I'm the Knowledge Management and Research Application Team Lead for Breakthrough Research. In this session, I'm going to tell you about our research spotlights. Research spotlights are interactive web features that highlight how current SBC projects are filling priority evidence gaps for integrated SBC and PBC programming. Spotlights are a great example of the RLAs being applied across health areas and different kinds of work. While these spotlights feature programs, interventions, and programmatic resources, the lessons and tools can also be used by researchers and donors. Spotlights are a great way to see the whole package of an SBC program, from the theory that drives the design to the implementation of the project and the results it achieved. Importantly, our spotlights also have embedded links to other resources that are useful tools. The first research spotlight I want to share was developed to showcase Pathfinder International's Beyond Bias project. This spotlight features the process by which Pathfinder used human-centered design approaches to address provider bias at family planning public clinics in Burkina Faso and Tanzania, and at private clinics in Pakistan. Beyond Bias employed a multidisciplinary approach that brought together experts in adolescent sexual and reproductive health, SBC communication, human-centered design, behavioral economics, and market segmentation to address the problem of youth contraceptive uptake. The Research Spotlight is an online interactive tool where you can navigate to the sections you are interested in. You can learn about the theoretical underpinnings of the project design and the priority questions of inquiry, walk through the process of project implementation, review project findings and the solutions that were developed, and finally, see how the project was evaluated and what evaluators learned about project effectiveness. In this slide, you can see the provider bias driver tree developed by Beyond Bias. This visual details an exhaustive set of drivers aggregated into 3 distinct categories that help clarify the behavioral antecedents of provider behavior. It shows 3 distinct subsets of provider biases that can be triggered, exacerbated, or ameliorated by specific adolescent demographic and behavioral traits. Understanding these drivers helped to shape provider profiles that were then used to tailor provider behavior change interventions. In the green box, you can see an embedded link to a resource that provides additional details. In this research spotlight, we feature Sergo Ventures Cube's framework and its application for SBC programming. This research spotlight sought to answer priority research questions from the RLAs around the organizational and individual characteristics and values that are most influential in shaping healthcare provider behavior, and the types of interventions that are most important in improving the quality of client-provider interaction. Like the Beyond Bias Spotlight, this is an online interactive feature that allows you to navigate through different sections of the project design, implementation, and findings to learn more about the project and explore resources that might be useful in your own work. Here you see the CUBES framework that articulates 3 critical components of behavior change. The Spotlight also allows you to explore 2 case studies that show how the CUBES framework has been applied in different health sectors. Using the CUBES framework, the Sergo researchers mapped potential factors that drive provider behaviors. These factors range from contextual issues, like infrastructure and supervisory support, to perceptual considerations like self-efficacy and beliefs about certain healthcare practices. At the same time, this CUBES mapping also revealed evidence gaps. Critical CUBES factors such as systems and processes, risk perception, and motivations, which typically influence health behaviors, were found to be under-researched and not well understood. The Spotlight includes guiding principles for researchers and program implementers to show how you can use the CUBES framework to gain a deeper understanding of behavior influencers and drivers for more effective SBC programming. To access these Research Spotlight tools, click on the QR code shown on this slide.
So thank you so much, Heidi, for sharing that. And a few more questions to hear from you all again using Mentimeter. As usual, please go back to where you left off on Mentimeter, or if you need to rejoin us, please go to menti.com and enter the code, or use the QR code here to take you to Mentimeter. So in thinking about the research spotlights that Heidi just shared as a knowledge management tool, we're curious in terms of a pulse check in general, how useful do you find this kind of consolidated knowledge management where you can find tools, theoretical underpinnings, and results in one place? Let us know if that's not useful or extremely useful or somewhere in between. Great, so it looks like we're staying pretty steady at leaning towards the extremely useful side, which is great to see. So thank you for sharing that feedback. And so as we're thinking about this kind of consolidated knowledge management and putting it into practice, question to you all. So in a short sentence, what do you think is the biggest challenge to accessing and using research and evidence, like what we've shared today for PBC, to inform programs? Thank you so much again for sharing your feedback around the challenges to accessing and using this kind of research and evidence to inform programs. And I know, Heidi, you're on the line, and I see some challenges coalescing around a couple of things that I think that the research spotlights intend to address. And so I wonder if you can talk a little bit about these challenges around being dispersed or knowing where to find the latest information, and this challenge around researchers not knowing how to translate it or not being taught how to translate it. And can you speak a little bit to how the research spotlights might address some of these challenges?
Sure. Thank you, Amanda. I think I do see a lot of overlap in this sort of sense of information overload and knowing where to go. We were all suffering from the information overload, which is not getting any better. I think one of the things we really wanted to do with these research spotlights is make them a one-stop shop. So you can go to the web feature and get the nuts and bolts on everything you want to know about the particular project and the insights that were gained. So packaging the information in a really easy to use, user-friendly way was really important, and especially providing a lot of links to resources that people can use once you dig in. We really tried to do both of those things with the research spotlights. The other thing I want to stress really is it's important to design when you're designing web features like this, as well as any sort of knowledge management platform or package, is making sure it can be used in low resource settings, as well as optimizing for mobile. We know that so many people use their phones to get information, and that's also a trend that is just increasing and not changing. So optimizing resources in your knowledge management platforms for mobile is especially important. Thank you.
Great, thanks Heidi. And thanks to you all for sharing your feedback, reactions, and thoughts. It's really great to hear from so many of you. And as always, please keep Mentimeter close by. We'll use it again in a few minutes. Now that we've shared some of the state-of-the-art evidence and tools you can use, let's look to the future and what we can do to continue to advance SBC and PBC approaches for quality of care and family planning. A primary call to action for everyone today. Future approaches to improve the quality of family planning services should commit to robust evaluation of provider behavior change interventions to enable comparable learning that supports policymakers to target quality improvement and invest in evidence-based behavior change programs. In particular, to continue to improve the quality of care of family planning services, program designers should commit to designing interventions that address providers' behavioral determinants, such as attitudes and biases, and that they are robustly evaluated. Service delivery program designers should consider SBC approaches as critical evidence-based interventions that can complement other quality of care or service delivery approaches to improve family planning outcomes through the identified promising PBC opportunities shared today. For those that are SBC researchers, we call on you to ensure that future research develops and validates new measures or adapts and uses existing measures such as the Provider Authoritarian Attitude Scale shared today to generate a more comparable and standardized evidence base that reflects the complexity and nuance of provider behavior. And finally, with this strength of the evidence base and the resources and tools shared today, donors should commit to investing in evidence-based provider behavior change programs and to requiring their robust evaluation and the standardized measurement of provider behavior and its determinants. With these calls to action in mind, we look to the future and what's next for strengthening PBC interventions. First, donors and programs should consider further testing of social accountability approaches to better understand the range of interventions that can effectively be deployed to improve family planning provider behaviors. Next, further research is needed to understand whether improving these behaviors of family planning providers influences the quality of care provided and to identify the most effective SBC approaches to improving quality of care. And as we continue to look forward, family planning program implementers and researchers should consider applying both a framework that captures the system-level determinants and a behavioral theory that captures individual determinants to better understand the drivers of provider behavior. Similarly, we look to the future and what's next for measurement of PBC. Moving beyond cross-sectional descriptive studies, beyond assessing skills and training-based approaches, measurements of core concepts of family planning provider behavior, such as provider attitudes and provider bias, are needed to concretely assess and address provider performance. Where possible, behavioral measures and family planning outcomes should be captured together, in addition to more immediate factors such as changes in knowledge, attitudes, and beliefs, changes in self-efficacy, and changes in the social norms that might influence provider behavior. Evaluations of PBC interventions should use a multimodal data collection approach to collect both provider-level and client-level outcomes to help elucidate how changing provider behavior is linked with improved client outcomes for family planning. Also, as we look to the future, we are excited to share that Breakthrough Research will publish a PBC-focused supplement in global health science and practice, featuring articles from our work, including what we've shared here today, and work from other implementing partners and collaborators to advance and strengthen PBC programming through program design, implementation, evaluation, and measurement. The overall objective of this supplement is to raise the profile of PBC in the global health community and highlight innovations in PBC research, programming, and evaluation framed by RLA evidence gaps. Articles in the supplement will be published on a rolling basis with a full launch in the middle of this year, so please be on the lookout for those announcements. So now we're excited to continue to hear from you one more time through Mentimeter. So please head back on over to Mentimeter, where we have a few questions that will help guide our discussion. Again, if you need to rejoin us, please go to menti.com and enter the code, or use the QR code to take you to Mentimeter. So first, thinking about the evidence gaps that were highlighted in the research and learning agenda: organizational characteristics and values, intervention strategies, effectiveness, and measurement. We're going to ask you to rank the following evidence gaps for PBC in order of most urgent to fill to least urgent to fill. So how would you rank these evidence gaps? There still seems to be some shifting, but it looks like right now effectiveness as a, things continue to shift, but effectiveness seems to be on top as the most urgent, along with intervention strategies and measurement, which keep swapping places for second and third, followed by organizational characteristics and values. And so this is great, and we hope that some of the tools that we've shared today can help to address some of these evidence gaps and fill some of these evidence gaps, particularly around effectiveness, measurement, organizational characteristics, and values. So again, just a pulse check, just trying to sort out where people are. Which tool that we've shared today do you see most applicable to your work right now? Is it the PBC measurement learning course? Is it the provider authoritarian attitude scale? Is it the research spotlights? Great. It's great to see that this is fairly evenly distributed. And so we're excited to see that these tools feel applicable to your work, and we look forward to seeing those applications. And of course, you have access to all of these tools through the links in the chat, and we'll of course follow up at the end of the webinar with the links to these so that you can get started right away using these tools. And then finally, as we look to the future, in one word, I know that's hard sometimes, but in one word, what do you hope is next for PBC approaches when it comes to quality of care for family planning? Great. It's great to see what you all hope is next for PBC approaches when it comes to quality of care for family planning. And we'll use some of your feedback from these different Mentimeter exercises to guide our discussion. But for now, we'll flip back over to our discussion question and answer. And so please post your questions in the chat if you have them. I know we've had several come through, and so we'll start to address those. And then with time, we'll also discuss the implications from the Mentimeter results that we've seen throughout the webinar. So first, an early question that came in following the expressions of power in provider behavior presentation that was shared. It says, I wonder if you also looked into the relationship of trust and power differentials or related them to social class. And I think Senyukta, you're on the line and would love to hear from you.
Hi everyone, I hope you can hear me okay. Yeah, and I think Sherry might have put my response in the chat. And thanks for raising the question. So we didn't look at sort of social class in the community specifically, but I think, and that would be interesting to explore in some subsequent work to see if the social class within a community and how that influenced provider relations. What we did see certainly was that there were sort of power and class by differentials by cadre of providers and sort of the varying levels of trust in the skills of the providers. So who has the authority? Would you be willing to question the practices of a facility-based provider, if you were a community-based provider, and even within the facility, even especially the nurses, we're talking particularly about the kind of differentials in power and experiences with the doctors. So even though they're doing the primary caretaking, what is that relationship like? So I think there's sort of classes by cadres within the health facility and the health system, but I think it would be good to situate that within the broader social class. And I think I'll pause there.
Great, thanks, Senyukta. I appreciate that. Going to another question from the chat. It was noted in thinking about the PBC measurement module that there were multiple behaviors in the definition. And so a question, Leanne, I think to you, how can we determine factors of multiple behaviors?
Thanks. Yes, this is something that we have contemplated and discussed quite a bit as a team, and even within a broader group with the SBC for service delivery working group. And I think one of the things is to think about what you're trying to influence in terms of behaviors, because it's true, you could be trying to focus on management behaviors, data collection, or you could be focused more, what we've kind of focused on in our work has been more on the client-provider interaction and trying to assess multiple components. You know, it could be sort of how they welcome someone, ensuring privacy, and that sort of thing. And so maybe kind of looking at sort of the cluster of behaviors that you're trying to affect through an intervention, or that you're trying to understand to inform an intervention, and then using that and creating sort of a theory of change to think about how the different elements may be associated with that specific behavior. But I think the important thing is to just try to maybe break it up into the domain that you're really kind of trying to focus on from a behavioral perspective, and then, you know, kind of look through the logic pattern of how you would influence that.
Great, thanks, Leanne. And I think there's questions around PBC measurements, questions about the provider attitude scale. So Martha, I wonder, as a first one, if you could talk a little bit about sort of any key messages that are coming out of the analysis guidance for the provider attitude scale from the technical reference sheet that you included in your presentation.
Mm-hmm. Yeah, thank you, Kristen. I'm not sure if I'm understanding your question correctly, but if I were to give you guidance in terms of the how to apply this scale, which is how I'm interpreting your question, I think one really important thing to consider is whether you have the resources and the time to pre-test the scale in the context that you're wanting to use it. So, of course, I mentioned we developed the scale in DRC, and we were able to test it in Togo as well. But context is everything, as we know. And so being able to conduct a small scale, possibly a handful of cognitive interviews in order to ensure that the constructs that the scale is measuring are contextually relevant. And so I think that would be the really high level guidance that I would give anybody who would want to use the scale, is if you can conduct a small test, I think that would be really beneficial.
Great, thanks, Martha. And then stay on the line, because there's a second question I want to ask, an interesting one from Aaron. Are there self-assessment tools that providers can use related to these measures?
Oh, I would love to test that out. So if Aaron, maybe you and I should talk. But so we have not tested these survey items as self-assessment tools. I think it's a really important question. We've used them, and we know they work as part of a provider interview within a larger study. And I'm really curious, if it were to be a self-assessment tool, what would happen over time in terms of how providers are responding to these. So I think that's a really interesting direction to take this in.
Thanks, Martha. And then one final question I just saw come in. You had talked a little bit about routine data collection mechanisms for this scale. So one question is just, what mechanisms are you sort of thinking about or recommending for PBC measurement, if you have any in mind?
I'm actually really looking for those of you who are on the ground and working with providers to get a good sense of how this can be done. So, I mean, I know Andrea's on the line, and I know PSI does a lot of data collection with providers of different cadres. And so I would think that this is more of a question that us as a community could answer. What are the routine data collection systems that are being used right now? And would this kind of measure work for that, or do we really need to be thinking about constructing something different? And so I really invite this conversation to continue.
Great, thanks, Martha. Another question that I see has come in that I think perhaps Sanyukta you could speak to from the expressions of power analysis from Laura. A lot of quality of care practitioners are also discussing respectful provider experiences, meaning the respectful treatment of providers by health systems and their clients as influencing provider behaviors. And to what extent have these experiences of abuse, disrespect, or neglect been raised in the PBC research findings? Sanyukta, any thoughts there from your analysis?
Thanks, Amanda. I think just to say that, yes, this has come up in some of our work. And I think we often sort of tend to talk about the challenges that clients have with providers. And certainly having worked a fair bit in adolescent sexual and reproductive health, we hear a lot about provider attitudes and norms towards younger clients and individuals who are seeking services. I think what was interesting in the provider, sort of our secondary analysis of data collected with providers directly, was how much sort of the reputation of the clinic in the community, individuals' assumptions about client experiences or experiences with providers, and oftentimes the disrespect of certain cadre of providers can influence how then that provider interacts with the community or any individual client. So I think one of the key things I hope, for me, has been in doing part of this work, is that we do need to be collecting data directly with providers and not just the clients, to sort of understand their perspectives in the social and behavior change programming world. Pause there, Amanda. I'm happy to take other questions.
Thanks, Sanyukta. That's great. And I'm just mindful of time. I know we have more questions that have come in the chat, and we've taken note of those questions. But in respect to time, we'll make sure that we follow up with your questions, and we'll provide answers as part of the follow-up email following this webinar. But for now, want to say thank you so much for such an engaging discussion. Your questions and your feedback through Mentimeter have been wonderful. And thank you for being with us for this hour and a half. Please use this QR code to access an accompanying legacy resource document. This will also be shared as a link in the chat and by email as follow-up to this webinar. And finally, just thank you again so much for joining us, and please do join us again for the rest of the webinars in our learning series. So on February 28th, we'll be discussing advancing SBC measurement for family planning. Please join us on March 21st to discuss SBC and the enabling environment for family planning, and on April 19th to discuss costing for family planning SBC. So thank you again for joining. We'll share out all of the resources. We look forward to seeing you again, and have a wonderful rest of your day.